All right, good morning. It's 6:30. We're going to go ahead and get started with the grand rounds today. I'd like to introduce Dr. Mogul, who's one of our surgical oncologists and is the director of our UWMC and Fred Hutch HIPEC program. He completed medical school and surgical training at the University of Mumbai and then completed general surgery residency at St. Louis University Hospital, followed by a fellowship in complex general surgical oncology at Wake Forest University. He then joined the surgical oncology team at the Medical College of Wisconsin, where he directed the Regional Cancer Therapies Program and concurrently earned a master's in clinical and translational science. Then about 5 years ago, he joined us as section chief of our complex abdominal oncology and mixed tumor service, and as mentioned, as director of our HIPEC program. He is author of numerous peer-reviewed manuscripts and other publications on HIPEC and the surgical care of patients with advanced abdominal cancers. Currently serves on the editorial board for the Journal of Surgical Oncology and Surgical Oncology Insight. Please join us in welcoming Dr. Mogul as he shares his expertise with us in his presentation on the journey of HIPEC.
Okay, hopefully everybody can hear and see. Good morning, everybody. Dr. Inaba, Dr. Wood, and Grand Rounds Committee. Thanks so much for that generous introduction and for the invitation to present Grand Rounds today. I have no disclosures. The only disclosure I have is really that I'm passionate about treating patients with peritoneal disease from appendix cancer. So before I start, I wanted to acknowledge something. Some of you may have seen The Lord of the Rings, which is a trilogy by Tolkien, and some of you may not have, and that's okay. This really isn't about pop culture. It's more about pattern recognition and telling a story in a structured manner. The Lord of the Rings is a classic trilogy that begins with a small object, the ring, which holds immense power, destructive power. Most ignore it, and sometimes it seems trivial, but when it's left unchecked, it corrupts everything it touches. Cue appendix. Over time, it becomes very clear that no single warrior or wizard or nation can defeat the threat alone, but it requires a fellowship, which is diverse, multidisciplinary, and sometimes unwilling, when formed, that can stop the power of this ring. So the path is long, it's filled with fear, it's filled with a lot of uncertainty, but through knowledge, collaboration, and endurance, folks succeed. Appendiceal cancer, much like the ring, has felt the same. It's rare, it's overlooked, misclassified, and it's deadly when ignored. And over time, with development of systems, the right tools, the right surgical teams, as well as systemic therapy advances, we have begun to turn the tide. So today I invite you on this journey, not as a fantasy, but as a metaphor. You don't need to understand the story. Remember, just follow the arc. So our roadmap or our objectives today mirrors the Lord of the Rings Tolkien books. We begin with the foundation, which is the background and classification of appendiceal tumors. Then we ascend through the trials of treatment. And finally, we arrive at a future which is shaped by recent advances and limitless possibilities. In Tolkien's world, a small object carries immense power. So too does a small organ like the appendix, which is often dismissed, which can harbor rare tumors with lethal potential. Like the first act in our series, our quest now starts with recognizing the danger of appendix tumors, especially when they're overlooked. So we begin this journey by understanding the origin of these rare tumors. So appendiceal neoplasms in general are a rare group of heterogeneous tumors, which occur in less than 10 per million people per year. So extremely rare, less than 1 to 2 out of every 1,000 appendix specimens that are removed, either for appendicitis or incidental findings, have an appendiceal tumor. While they can be diagnosed in the setting of appendicitis, appendiceal tumors often present late with peritoneal disease, especially mucinous neoplasm. And prognosis significantly varies based on pathology, and patients unfortunately often die in the setting of disseminated disease if not treated or caught early. So what is this entity called pseudomyxoma peritonei that we allude to very often when we talk about disseminated appendiceal tumors? This is first described back in 1882 by Perth when they described a ruptured cystadenoma of the ovary. So it was thought to believed to be originating from the ovary, and with a clinical entity characterized by gelatinous ascites. So, you know, um, I describe this to patients as not like a fluid within the abdomen. This gelatinous ascites arising from a heterogeneous group of tumors or pathologic condition, which comprises abundant extracellular mucin with or without epithelial or neoplastic component. And it was not until 1901 and later at 1903 when it was published that appendiceal cancers and pseudomyxoma were more related in origin to mucoceles, which arise from the appendix. However, this disease has really eluded us, and only in the last couple of decades, there has been some significant work that has been done by some very important groups in trying to attempt to classify these tumors as a first step moving forward to understanding this somewhat esoteric condition. This journey, however, required several iterations, as you will see. So Ronnet was the first and the earliest to describe classification of pseudomyxoma peritoneal or appendiceal cancers. Based on the diagnosis of the primary appendiceal tumor as well as the peritoneal lesions, the lesions were classified into three categories. The first category was DPAM, or disseminated peritoneal mucinous adenosis, which was basically bland appearing appendiceal tumors, almost benign appearing, with peritoneal lesions that were predominantly mucin with some strips of bland epithelium, but no high-grade features to suggest carcinoma. And historically, these were considered quote unquote benign. On the other end of the spectrum was the PMCA, or the peritoneal mucinous carcinomas. These were lesions where the appendix clearly showed evidence of a high-grade malignancy, and the peritoneal lesions showed similar mucinous cancer. Then there were the intermediate and the discordant tumors. The intermediate tumors were those in which the primary appendiceal tumor was an adenocarcinoma, whereas the peritoneal lesions were more bland, much akin to the DPAM tumors. So their prognosis were similar to DPAM. Whereas the discordant tumors were those where the appendix appeared very benign, and without evidence of an actual transition from an adenoma to a carcinoma, the peritoneal lesions appeared very highly malignant. Even though this was a good first attempt at classifying these tumors, there were several problems that this classification had. One is, as noted earlier, DPAMs were considered benign, which clearly it's not, as you can see from the survival curve. Even though it's excellent, there's still people that die from this disease. Secondly, they clumped together the intermediate and discordant tumors, which now we know is not necessarily the right thing to do because their biology and outcomes are very disparate. And lastly, this classification system was really challenging for clinicians to understand because it really didn't give people a biologic base of reference that they could use when making decisions for treatment. So we then came to the Bradley classification, and arguably this made a lot of headway in terms of providing a biologically relevant system of classification that was more clinically applicable. So in this system, they used low-grade and high-grade cancers. People were divided into these two general groups. The erstwhile DPAM patients, as well as some of the intermediate risk patients, were included in the low-grade mucinous carcinoma peritoneal patients, and the high-grade patients, the erstwhile PMCAs, were included under high-grade mucinous carcinoma peritoneal. And because even cases with low-grade disease and peritoneal cytology that did not look aggressive and that had spread beyond the right lower quadrant required treatment to prevent progression in the future and death, all of these cases were uniformly classified as malignant. So it put an end to the debate of whether pseudomyxoma can ever be considered a benign entity. And while this classification was more biologically relevant and clinically relevant, it failed to capture, again, some of the important nuances of intermediate and discordant findings in the appendix and the peritoneum, but it did lay substantial groundwork for classification systems that we now currently use. This is another classification that was devised by Pi. Now, this looked mostly at the primary appendiceal tumor and used a risk of relapse-based system of classification. So based on what we saw in the appendix and in its immediate vicinity, classified patients as either quote-unquote adenomas or low-grade mucinous neoplasms that had low risk of recurrence or those that had high risk of recurrence, and then the frank or overt mucinous carcinomas. And all of these systems sort of combine eventually to help provide some sort of consensus with how we classify these patients currently. So finally in 2012, which in retrospect now seems like a long time, but wasn't a long time when I was still training. We had some consensus that was arrived at based on an international conference that was held in Berlin in 2012. And experts from various fields, pathology, surgery, medical oncology, and multiple other specialties gathered together to form a consensus based on this modified Delphi process. This Delphi process basically uses consensus through a series of anonymized surveys that are provided to experts. And the goal is to leverage their expertise in providing shared understanding of the disease process. The experts then, with each round of consensus building, receive very defined feedback that was used to help shape their subsequent opinions. And this basically eventually filtered down into forming a consensus classification that we know now has resulted in a consistent reproducible nomenclature that is predominantly used today. So based on this classification, this is how we now classify appendix cancer. So we classify the primary appendiceal tumor different, not necessarily in discordance with, but different from what we classify the peritoneal lesion. And the primary appendiceal tumors can be classified either as appendiceal mucinous neoplasms with or without infiltrative invasion. So the tumors without infiltrative invasion don't have the classic hallmarks of the classic adenocarcinoma. They have what we call pushing invasion, which means the mucin forms a broad front that eventually faces the wall of the appendix. And with time, an effacement of the wall can lead to rupture and dissemination. Whether these lesions are low or high grade depends on the cytologic atypia of the mucinous epithelium per se. By definition, these tumors don't involve the submucosa, so the likelihood of nodal metastases is very low. Hammond is a relatively, or high-grade mucinous neoplasm is a relatively newly defined term. And while there's some evidence today that it might be a little bit more aggressive than Lamin in terms of its presentation, we just don't have enough published evidence on how Hammond tumors behave long-term. So the more classically defined patients that we see are the Lamin tumors or the low-grade epithelial neoplasm. As seen in these slides, there's a CT image, a laparoscopy image, and a specimen image. These often present as the classic quote-unquote mucoceles on imaging. So they're dilated, fluid-filled appendix with occasional wall calcification, but no evidence of surrounding organ invasion like the cecum or the terminal ileum, and rarely, if ever, there's any lymphadenopathy in the ileocolonic mesentery. Now, the appendiceal mucinous neoplasms with infiltrative invasion, which is the quote-unquote classic adenocarcinomas, they have high-grade type pathology and cytology, and they have the classic features of adenocarcinoma like desmoplasia and submucosal involvement. And depending on the pathologic subtypes, they may be classified either as mucinous or non-mucinous, and each of those then can be subclassified as well-differentiated, moderately differentiated, and poorly differentiated with significant cell pathology. Often these tumors, as depicted in the scan on the left side, present with localized infiltration of the ileocolic mesentery. So when you see a mass-like area in the ileocolic mesentery, you get very suspicious this is more of a high-grade adenocarcinoma type pathology. The appendix is often not identified separately, and oftentimes there is regional adenopathy present both clinically as well as on pathology. In terms of pseudomyxoma peritonei, a couple of points. So irrespective of the primary, whether it's a low grade without infiltrative invasion or a high grade with infiltrative invasion, the general schema of peritoneal studying is pretty similar. So what happens is that the tumor cells detach, then they transport using the principle of redistribution, which we'll go over shortly, and then they attach to the distant peritoneum and they invade. So it brings us full circle back to pseudomyxoma peritonei. So technically, when we talk about pseudomyxoma peritonei, we're talking about the spread of mucin with or without cancerous cells outside the right lower quadrant, with deposits that accumulate in accordance with the principle of redistribution. What that means is that there are areas of high traffic where fluid gets absorbed and the cellular components get left behind. And these cellular components in turn divide and form bulky tumors. Hence, you see distribution of disease in high traffic areas like the omentum, the subdiaphragmatic spaces, the pelvis. Without this typical pattern, we typically can't qualify patients as having pseudomyxoma peritonei. This process is always considered malignant, and it's very important to remember, as we saw just now, that the prognosis of patients really depends on the pathology in the peritoneum rather than truly the pathology in the appendiceal primary. So accordingly, based on the SOGI classification that we talked about earlier that was based on modified LP, we pathologically classify pseudomyxoma peritonei either as low-grade mucinous carcinoma peritonei, which typically arise from the Lamin type patients, high-grade mucinous carcinoma peritonei, which typically arise from adenocarcinomas, and then the high-grade mucinous carcinoma peritonei with signet ring cells, which arise from poorly differentiated cancers. And these go in order of their prognosis from low to high. Oops, sorry. So this brings us to Act 2. So in Tolkien's world, this is where the battle intensifies. The peritoneum becomes our Helm's Deep. Hopefully some of you understand that reference. And HIPEC and cytoreductive surgery becomes our fortress. And it's in this peritoneum where the battle is fought most hard. And despite the potential, in Tolkien's words, if I were to paraphrase, despite the potential for late presentations and advanced disease, there is still hope for a reasonable outcome, and so we press on. Having understood this classification, we can now use this to inform our battleground strategy. So how do we treat Lamin tumors that are confined to the appendix? So typically, these are cured with appendectomy alone. Lamins that have been treated with appendectomy but have tumor at the margin oftentimes are treated with re-resection. It's important to understand that while re-resection happens quite often, oftentimes on final pathology, there's no residual tumor. And in terms of implication, this really doesn't have much of an implication in terms of overall survival, but those people that do have positive tumor on re-resection can have a slightly shortened disease-free interval. So really based on that, many a times we recommend re-resection versus sometimes we might just recommend observation. Especially in the setting of patients that have acellular mucin only on the resection margin, we often don't recommend re-resection. We don't routinely recommend right colectomy. As I alluded to earlier, these patients typically don't have infiltration. And so because there is no submucosal involvement and lymphatic infiltration, rarely do these ever cause evidence of lymph node metastases. And therefore, routine right colectomies are not indicated. I have seen this paradigm shift in how we treat these patients, especially out in the community. And while most of these patients used to routinely undergo right colectomies when a tumor was seen on a scan, we're now becoming selective because of consensus guidelines where people are not doing this often or routinely for most patients with what looks like Lamin tumors on scan. Now, the important thing to remember when we counsel patients, though, and we see these patients often in our clinic when they have a Lamin tumor and no one knows what to do with it, is how to talk to them about their risk of developing pseudomyxoma peritonei in the future. And that is an important discussion to have and is informed by some of the retrospective data. Their risk of developing pseudomyxoma is highest if they have mucin outside the appendix, on the surface of the appendix or in the right lower quadrant, so there's limited rupture, especially if that mucin has epithelial components. If the mucin has no epithelium, the risk is intermediate. And if there's absolutely no mucin outside the appendix, some people will argue their risk is 0, but there are studies that show even in those patients, there can be a risk of developing pseudomyxoma in the future. And so my preference often is to follow patients, especially when they're young and they have some risk factors, to follow them and to follow them late, because oftentimes when recurrences do happen, they can occur fairly late, up to 10 years. And usually we follow them with serial CTs and decreasing frequency of intervals as time passes on, as well as tumor markers. This brings us to one of the topics that had interested me at one point in what do we do about, sorry, before that, we talk about appendix adenocarcinoma. So these, like we saw, have classic infiltrative invasion. So they're classic adenocarcinomas, and we treat them as such with regional lymphadenectomy along with appendectomy. So right colectomies are routinely indicated. And not only is this important to clear disease, but more importantly, it's an important strategy to fully stage patients, and as a result of which we can inform our strategies for adjuvant treatment. So typically in patients with node-positive disease, and sometimes depending on risk factors, patients with T4 or perforated tumors or tumor deposits or presence of mesoappendiceal invasion, we often will send patients to medical oncologists to have that discussion. And because these are higher grade lesions and a higher risk of recurrence, both distant metastases as well as in the peritoneum, surveillance imaging is often indicated, and it's often more frequent. So this brings me to an important topic that is of relevance to a lot of us, because we often see appendiceal masses that have been diagnosed in the setting of patients not having classic appendicitis, that have been diagnosed in the setting of incidental finding as a matter of workup for some unrelated cause. And what do we do with this? This is an issue that is little understood, because even though we know the incidence of cancers within appendicitis or appendices that are removed, we don't know what to do when they're radiographically. And so I recently did this study with one of my students where we looked at all patients within the last 10 years who had an incidentally noted abnormal, quote unquote, abnormal appendix in the setting of unrelated workup. And we termed these abnormal appendices using some defined set criteria as appendiceal incidentaloma. And of more than 5,000 patients that we found, 9.3% were noted to have appendix incidentalomas. And based on the finding of what radiology said, some patients went to the OR and some patients obviously did not. Those patients that went to the OR as a result of being diagnosed radiographically as having an appendiceal neoplasm, the diagnostic accuracy, which means how many of those people were found to have appendiceal neoplasms on pathology, was close to 68%. So I would say pretty good, but certainly not perfect. On the other hand, of the patients that were diagnosed as quote unquote radiographically benign, some of them still went to the operating room, and about 24%, so 1/4 of these patients had an appendiceal tumor. All of this is to say that our imaging techniques, while somewhat give us an idea of whether give us an idea of the actual pathology, they're not very accurate. What we did find, though, in the study, when we saw patients that had more mature follow-up, so for a median of approximately 55 to 57 months, that in those patients, even that did not go to the OR with quote unquote radiographically defined neoplastic tumors, as long as they were followed in a long-term fashion, did not die of their appendiceal neoplasm. Now, granted, some of that follow-up we lost because patients either didn't follow up or they had medical problems for which they were not going to be undergoing resection, or they were older. But none of the patients in this entire cohort actually found died of their appendiceal disease, as long as they were followed, and we had follow-up for them. And this has some implications in terms of how we manage these incidentalomas, especially in patients that are high risk for surgery. So say in an average 40-year-old with an abnormal appendix, you may make the argument to take them out, even if the radiologist doesn't necessarily cause a neoplastic condition. But in an 85-year-old, for example, with multiple medical comorbidities, even in the presence of quote unquote radiographically neoplastic tumor, as long as we can follow without any substantial change, you might make the argument to say, watch them. And that brings us to the next paradigm of treatment. So why do we do CRS HIPEC in patients that have peritoneal disease? So the management of disseminated peritoneal disease is predicated on, especially in appendiceal mucinous cancers, is predicated on CRS HIPEC, as we will see throughout this talk. This is obviously an aggressive strategy because it's a big surgery with potential morbidity. But when applied in the right patient, it can really lead to good long-term outcomes. And the rationale is that after a complete cytoreductive surgery, which means removing all the visible tumor via peritonectomy and multivisceral organ resection, HIPEC can then be utilized to control the remnant disease in the peritoneum. Hyperthermia increases the penetration of chemotherapy at the peritoneal surface. Hyperthermia also has direct cytotoxic effects because it induces apoptosis and also activates heat shock proteins, which serve as receptors for natural killer cells, and it also inhibit angiogenesis. And through these different mechanisms, cytoreduction and hyperthermia can achieve substantial tumor kill of residual or microscopic disease that's left behind after the initial surgery. The choice of chemotherapy agent is kind of important to understand. The ideal agent should be hydrophilic, so it doesn't cross the plasmaperitoneal barrier. It should have a high molecular weight, so it stays within the peritoneum. It should have excellent tumor penetration, so that obviously it has effect on the tumor. Have good heat synergy, and it should have a high peritoneal to plasma AUC, which means more of the chemo stays within the peritoneum, less gets absorbed. So you maximize efficacy and minimize systemic toxicity from absorption. And as noted here, mitomycin serves a lot of these criteria and therefore has been very popular for use in patients with appendicitis. However, not all patients will benefit from CRS HIPEC, and it's really important to understand how to select these patients when you're counseling them for surgery. And most of the time, this requires careful tumor board review. So of several factors, pathology, I would say, is one of the key factors and arguably the most important factor that determines outcome. And if there's one message I'd like everybody to take away from this presentation today, it's this slide that summarizes a lot of it. As noted here, and in several studies of the similar kind, patients with low-grade disease or low-grade mucinous carcinoma peritoneum have excellent long-term outcome. The 5-year survival tends to exceed 90%. In patients that have high-grade disease without significant cell or just high-grade disease, their survival is still reasonable if they achieve a complete cytoreduction, so close to a 45 to 50% 5-year survival rate. However, in patients that have carcinoma with signet ring cells, their survival, unfortunately, is fairly under 12. The median survival is approximately 12 months, even with CRS HIPEC. And in this context, it's worth mentioning one particular subset of patients, and that is patients who have what we describe as acellular syndrome. So in about 30% of patients, when we see disseminated peritoneal disease and we do CRS HIPEC, the pathologist tells us that all they could identify is acellular with no cellular component. These are the patients that tend to do the best for obvious reasons. Their disease-free survival as well as their overall survival tends to be excellent. Most of these patients are beyond 10 and 15-year survivors. And in these patients, there are a couple of reasons why that happens. One is obviously because of the lack of or absence of cellular component in the peritoneum, their prognosis overall is excellent. 2, they tend to present with lower disease burden, and therefore, as a result, their ability to obtain complete resection of all the tumors is much, much lower. And if I were to use the term cure, remember, all of these are considered malignant and stage 4, but if I were to use the term cure in a patient in the setting of CRS HIPEC, it's probably this subset that I would use. The next set of factors that really affect the outcome is the PCI score and the CT score. But before that, I wanted to quickly allude to this staging system, which is the AJCC staging system. This kind of mirrors the initial the SOGI classification that we had described earlier, where we classify patients as well-differentiated, moderately, and poorly differentiated tumors. And prognosis, as we have seen in the previous slide, mirrors what was there. This is a study that, again, I did with one of our students that looked at validating this AJCC system in the context of the recent classification. And it turned out that the system performed really well. So the other factor that we were talking about is PCI score and CC score, which is a significant factor in determining outcomes. Now, for those of you who have worked with me in the office and in the OR, hopefully you know what this score is, but just as a review, the PCI score stands for the Peritoneal Cancer Index, and it is the objective score of the volume of disease that is noted into the peritoneal cavity when we initially explore patients. So we divide the abdomen into 9 regions and the small bowel into 4 regions, and each of these is given a score between 0 and 3, depending on whether you see no disease versus you see a significant amount of disease or confluent disease. And so your PCI score can be anywhere between 0 and 39 from low to high. And it's a way that we have used scoring of peritoneal disease to standardize volume of disease, to record the volume of disease in a standardized fashion so that we can compare across groups and across institutions. But arguably more important than the PCI even is what we call the CT score. So while PCI is what we see when we start the surgery, CC score is what we are left with at the end of the operation. And as we know in all cancers, complete removal is what we are always going for. So CC score of 0 or 1, which is where we leave no visible disease behind, or at least disease nodules that are less than 2.5 millimeters, is what we are always striving for when we treat patients. And that, by definition, is considered complete cytoreduction. Want to make sure, yep, okay. So when it comes to prognosis, like we said, the CC score is really important. So this slide basically shows you what happens in low and high grade patients with different PCI thresholds as well as CC scores. So the gist of this slide is that in low grade patients, while the CC0 patients, as indicated in the blue line, do the best, even CC1 and CC2 patients do reasonably well. So there is some benefit when we can't achieve a complete cytoreduction in low-grade patients. And so we almost universally give these patients an attempt at exploration. In high-grade patients, on the other hand, as you can see, what really matters is obtaining a CC0 cytoreduction. So even CC1, where we leave tumor nodules of 2.5 millimeters, is not acceptable. And conventional use of wisdom used to dictate that the higher the PCI, the less the benefit of cytoreduction in high-grade patients. Because even with a complete cytoreduction, they don't do well. But this has been disputed with recent studies. So if this third table looks at different PCI thresholds in high-grade patients who have undergone CC0 cytoreduction, and you can see even with PCIs well above 25, if you do achieve a complete cytoreduction, their median survival is pretty much similar as PCI scores lower with complete cytoreduction. The problem is once your PCI starts to exceed 20, 25, the likelihood that you're going to be able to achieve a complete cytoreduction goes down substantially. So that's why the CC score tends to be more of an important determinant in prognostic determination than the PCI score per se. And then several groups have investigated whether systemic therapy is particularly helpful in improving outcomes, especially in the neoadjuvant setting for disseminated. So for example, in this study, they looked at patients who had high-grade pathology that underwent neoadjuvant treatment, and more than 90% of patients that were on neoadjuvant therapy either had stable disease or they had improved disease, and only 8%, approximately 8%, had progressive disease on neoadjuvant treatment. And interestingly, the survival difference as noted in the survival curve between those undergoing neoadjuvant as well as no neoadjuvant therapy wasn't different, at least not statistically. Now, a couple of things to keep in mind. Those that did not receive neoadjuvant treatment did receive at least some form of adjuvant therapy. So this was not a chemo versus no chemo study. And more importantly, they didn't really define the criteria by which patients were selected for neoadjuvant treatment. And it's very likely that those that did get neoadjuvant treatment actually had a much higher burden of disease and therefore got neoadjuvant treatment before cytoreduction and HIPEC. And despite that, their survival was comparable to patients that didn't have neoadjuvant treatment. So even though this kind of sheds light a little bit on the role of neoadjuvant treatment, it doesn't really show that it truly improves outcome. So if it doesn't improve outcome, can it be used as a strategy to select patients instead? And that's sort of how we come to some of the more modern day paradigms for using neoadjuvant treatment. In this study, which has been widely credited as establishing the role of neoadjuvant treatment in patients with high-grade disease or disseminated appendiceal mucinous cancers, most patients receive neoadjuvant treatment and with common neoadjuvant strategies like FOLFOX and Avastin that we use regularly in patients. So more than 70% of patients did receive neoadjuvant treatment, and of those, 90% had stable or improved disease. Again, much like the previous study, only 10% progressed. So we know that on neoadjuvant treatment in high-grade patients, progression is not really a huge problem. And much like the last study, there was no difference in survival between neoadjuvant and surgery first groups. However, in patients that did undergo neoadjuvant treatment, there were several factors that independently predicted outcome in terms of overall survival. So presence of mucinous histology, presence of significant cell cancers, lower PCI score, and most importantly, the radiographic stability or response. So those that had stability or response did very well long-term when they were selected for surgery. So The bottom line is that neoadjuvant treatment may not necessarily directly influence outcome, but if used correctly as a selection tool for which patients should undergo surgery, is an excellent strategy. Finally, obviously, we can't discount the role of the elusive tumor biology, which has obviously gained a lot of attention in the last several years for treatment of several different cancers. And while tumor biology is somewhat still a nebulous concept in appendix cancer because it's a rare disease and not often studied, we have some idea now from some of the somatic mutational profiling in how tumor biology plays out. So the common mutations, as noted in some of the earlier studies and even today, are KRAS mutations, which are present nearly in almost 100% of patients with low-grade tumors. GNAS mutations similarly are shared between low and high-grade patients, arguably more common, a little bit more common in higher-grade patients. And then P53 mutations are almost always seen mostly only in high-grade patients. The chance of having a microsatellite high tumor with appendix cancer is extremely low, so less than 1%. Versus in colorectal cancer, even in sporadic colorectal cancer, it's close to 25%. And so our ability to treat with systemic therapy, especially immunotherapy, becomes very limited in this tumor. The same thing with other targeted therapies like anti-BRAF therapies, because the incidence of mutational BRAF tumor is so low, we have very few options that can be utilized in treatment of infection, except for systemic therapy that has been extrapolated based on colon cancer guidelines. And this is another study that I did with a student a while back that looked at a systematic review of all the different studies looking at mutational profiles. And we found pretty much the same thing. What we learned was that both primary and metastatic tumors, the mutational profiles tend to be very concordant. There's more KRAS and GNAS mutations in low grade and more GNAS and TP53 patients in high grade tumors. And there's no clear association between survival and the somatic mutations. Now, the problem is that we couldn't parse out those people we couldn't parse out the pathological subtypes with the individual mutational profiles in large numbers to do these survival analysis because we didn't have any raw data. And now, more recently, we have started to understand that even though these individual mutations may not have an impact or at least demonstrable impact on survival. When you look at these co-occurring mutations in patients and you analyze patients and subgroups based on these co-occurring mutations, patients with predominant RAS-type tumors and no GNAS or P53 tend to do the best, irrespective of pathologic subtype. Whereas those patients with GNAS predominantly mutated tumors and TP53 predominantly mutated tumors do the worst. And this is another way of looking at the biology that is somewhat independent of pathologic subtype, which does not always correlate with outcome. So finally, to our Act 3, we're getting close. And this is the act which sort of heralds our future, where science and emerging technology and precision medicine rise up and save the day, much like Tolkien's protagonist Aragorn, who restores hope. And one of the key battles of this new frontier is actually trying to improve early detection. And as a background to that, while standard high-resolution imaging has become, so much better than it was a couple of decades ago, it's still not a great way to try to detect very early recurrences that are small. And MRI arguably might be a little bit more beneficial in mucinous tumors, but still not able to, it's still plagued with problems like inter-observer variability and artifact. Serum tumor markers, they can be somewhat informative, but they're notorious, especially in people that are not producers. And laparoscopy, you could consider as detecting as a good modality to detect early disease. However, you can't subject everybody to laparoscopies every 3 months. And secondly, the benefit of laparoscopy in someone who's already had a massive operation is limited. So this brings us to the world of ctDNA. So for those of you who are not familiar with this concept, I can't go into the details, it's not really within the purview of this talk, but in general, ctDNA is circulating tumor DNA, which is either single or double-stranded DNA that's released by the tumor cells into the bloodstream, and typically tends to harbor the original mutation of the tumor. ctDNA can be derived from the primary tumors or from the metastatic sites or both. And often referred to as liquid biopsy, this has shed new light on some molecular mechanisms for spread, as well as monitoring and treatment of cancer. ctDNA has been utilized now for at least a decade in the early detection of cancer, particularly colorectal cancer, as well as mutation profiling for personalized cancer therapy, and also in clinical trials to monitor for response as well as drug resistance. The problem is with peritoneal disease, especially in appendix cancer, there are significant limitations to its use. So firstly, in comparison to other visceral sites of metastasis as seen in this diagram, in peritoneal disease patients, ctDNA often fails to get shed. And there are two reasons for this. One is the plasma peritoneal barrier, and secondly, mucinous tumors tend to hide these neoplastic elements really well. Lastly, paucicellular tumors like low-grade tumors don't shed a lot of DNA to begin with. So this modality to detect early disease may be somewhat limited. Also, we know that in non-tumor-informed ctDNA assays, the concordance between what we see as the mutational profile in the tumor versus what we see in the plasma often is not 100%. And so that can lead to some confusion with how to treat patients. So this brings us to tumor-informed ctDNA. And the basic premise behind this test is that we use the formalin-fixed specimens of the tumor to extract the genomic DNA, which is then used through a fancy algorithm and mechanism to create a personalized genomic assay that detects the presence or absence of specific tumor variants. So it's tailored to every individual patient. That's your Signatera assay. Even with tumor-informed DNA, the utility of ctDNA in appendix cancer is mixed. For example, in this study, for patients undergoing surgery for disseminated appendiceal cancer that were followed with serial ctDNA measurements, ctDNA was frequently negative, as indicated by the hollow circles on this graph, even in the presence of significant disease and recurrence. So it was not really helpful in monitoring patients long-term. In another study, however, when they used ctDNA for peritoneal disease with both high-grade pathology, as well as some colon cancers, this modality was a little bit more promising. In 90% of patients that recurred, there was some element of ctDNA either being stable or slight progression. In those that had stability of ctDNA, there was not a lot of information obtained in terms of their long-term outcome. But those that typically had progression in ctDNA universally had very bad outcomes. And ctDNA did predate the rise in tumor markers as well as the actual detection of CT-based evidence of disease, so on radiographic imaging, by approximately 3 to 4 months. So this is one of the tools I would say that we have in our toolbox, certainly not perfect and can't be really generalized, applied in a generalized fashion to all patients with parents. And then lastly, we need to mention the personalized therapy approaches that we have. And in this space, we have tumor organoids, tissue slice cultures, and various mechanisms that we use to grow tumors in the lab and study both the tumors as well as their microenvironment. Especially valuable in patients with rare diseases. So tumor-derived organoids, also called as patient-derived tumor organoids, these are cultures of tumor cells that mimic what happens in the actual patient body. So it has both stromal elements, epithelial elements, and the microenvironment. And they capture tumor heterogeneity with a high degree of fidelity, and therefore can be used to study biology, as well as they can offer a really good platform to study individualized drug testing. So this is one of the earliest studies that came out of the Wake Forest lab that looked at ctDNA. The slides may not translate well, but in general, there are green staining as well as red staining cells. The green are the viable, the red are the dead cells. So it's a live image that demonstrates both with low-grade as well as high-grade patients that are treated with these commonly utilized systemic agents as noted below, so FOLFOX, FOLFIRI, regorafenib, 5-FU. We can actually see changes in cell death when these organoids are subjected to chemotherapeutic management. Importantly, this demonstrated the feasibility of forming organoids in patients with appendix cancer that was long considered back in the day a dream, especially in paucicellular tumors like low-grade appendix cancer. This platform has also been used to test intraperitoneal sensitivity of mitomycin and other drugs like cilaplatin, and not just test the sensitivity of the drug, but also test the sensitivity at different thresholds of hypersensitivity. So this is just an example of the different patients that they included in their study, showing different variable levels of sensitivity. And you might think of this as a way to offer a personalized platform or an assay to decide which patients get what chemotherapy and at what temperature. This hasn't been translated into the clinical realm yet because there are certain disadvantages, or not disadvantages, but there are certain issues with this. For example, the lag time it takes to actually develop organoids and get information in a time-sensitive fashion. And oftentimes what even happens with organoids doesn't necessarily translate to clinical outcome. Lastly, I want to mention a couple of lines so that we get done on time on our approach at UWM. So since our inception of the program in 2020, we have taken a really patient-centered approach, which we built around multiple key pillars. So first and foremost is community engagement, where we ensure we are connecting with our patients through outreach, partnerships with patients, and local providers, more importantly. And we do have our social media and website presence too. Clinical care is something I'm extremely proud of based on our multidisciplinary teams that we have built. We have really been doing a good job providing fast multidisciplinary care to patients and access to patients. We try our best to integrate supported services that are part of this team. We follow best practice protocols, including the ERAS protocols, all while meeting national benchmarks. Our research and innovation efforts are still obviously underway, and thanks to Dr. Sherib, we have an outstanding tumor biobank with a lot of efforts to try to study some of this on the translational side in the lab. We're trying to bring some multi-institutional studies to our institution. We also participate in multiple consensus-based guidelines nationally, some of which are hopefully going to be published in the next year or so. And the goal is that we would build a robust database that can be translated in the multi-institutional setting. And lastly, through education. We try to promote continuous learning. So we have patient education events that we hold regularly. We had our third annual HIPEC patient education event this year that had more than 150 registrants. And we're also obviously dedicated to educating our residents through formal didactic sessions in our section meetings. And together, I think these pillars create somewhat of a high quality experience that is centered around patient data. And so at the end of the day, what we have learned about biology is now far more complete in terms of the map of understanding appendiceal cancer than it used to be. The optimal systemic therapy for patients, for managing patients, especially with high-grade disease, is still not defined. Whether to do neoadjuvant, adjuvant, or no chemo at all is probably going to require a randomized trial. Early detection tools like ctDNA for detection of molecular residual disease is still somewhat nascent and might offer some hope, but still requires a lot more refining. And lastly, personalized therapy may become our sort of healing elixir. So sort of a real world tool that helps us improve survival in this sort of complicated landscape. And lastly, much like Tolkien's story, our story isn't over, right? With every patient, every paper, every protocol, we continue to work. The fellowship that we're a part of is multidisciplinary, committed, compassionate, and it remains strong. And with that, I'll conclude and take any questions. Thanks, Dr. Wood. So for those of you who may not have heard the question is, does utilizing neoadjuvant therapy uh, actually translate into making clinical decisions relevant to selecting patients for cytoreduction in HIPEC? And I would say the answer is both yes and no. In our protocols, because we know that progression on neoadjuvant therapy is rare, but instead defining which patients respond and eventually that translates into a better outcome is seen more often. We do include neoadjuvant therapy fairly routinely in our protocol. Now, having said that, as with much decision-making in appendix cancer, the decision is shared. So it really depends on the patient and our multidisciplinary review. For example, there may be a patient that has predominantly mucinous disease that's aggressive, that responds to neoadjuvant therapy that we take to the operating room, and they have a good outcome. On the other hand, there may be a patient that has mucinous disease that's somewhat aggressive, that doesn't have significant progression, but has some mild progression in various sites in the peritoneum. Do we not select them for surgery? No, but we're careful to know that these patients are more likely to recur at a higher rate and much sooner than patients that do respond. Especially in the setting where they say, for example, have multiple other risk factors that make them ineligible for surgery. So if they have, for example, progression based on neoadjuvant therapy, they're also borderline in terms of their performance status. They also have certain mutations that we know are likely to make them high risk, and they have other high risk features. Then when these different multiple risk factors stack up, we might make the decision not to proceed. But we don't use that completely in isolation. Yeah, that's a great question. So some of it really depends on pathology. So I didn't put up the actual AZT with stage 4. All of these patients are considered stage 4, stage 4A, B, and C. The stage 4C patients are those that have both peritoneal as well as extraperitoneal metastasis, and their prognosis is good. Now, if the thoracic disease is more a result of extension from the diaphragmatic disease in the abdomen, I might be more inclined to do something. But if patients develop thoracic disease, other sides independent of abdominal disease, the prognosis tends to be pretty poor, especially when it is more high grade rather than low grade disease. I know we've shared patients, but those were predominantly low grade that did well. So again, nuanced discussion to be had, not much data to guide us, but something that needs to be considered, in a multidisciplinary fashion. So all excellent questions. So Dr. Sham was asking about CRS HIPEC, specifically, I assume HIPEC in patients that have non-appendiceal pathology, gastric and the pendulum in terms of colon cancer, I would argue, has swung a little bit. I mean, if you ask the Europeans, for example, they have moved away from HIPEC completely. In North America, we have taken a more selective approach. So the PRODIGE study, for those of you that may not know, the PRODIGE 7 study basically looked at the question of whether addition of HIPEC to cytoreduction alone has any benefit in long-term survival, both in terms of overall as well as disease survival. So all patients who underwent neoadjuvant treatment had both cytoreduction, but only half the patients underwent CRS with HIPEC and half had only cytoreduction. And the trial was in essence negative. Now, there were some problems with the PRODIGE study, especially we in North America consider those significant problems. Besides the trial design overestimating the benefit of HIPEC and therefore the number of patients that were actually accrued, the trial used a drug called oxaliplatin, which they used for a very short duration at very high dose. And we know that for optimal chemotherapeutic response, there has to be a balance between the dose that we provide as well as the duration. Arguably, a lot of these people who are getting oxaliplatin within the peritoneum were already being treated with FOLFOX. So if you can imagine someone that had neoadjuvant therapy with FOLFOX, now they're being taken for CRS HIPEC, you expect that the clones that are remnant in the peritoneum will be likely resistant to oxaliplatin. And these are the patients that were getting oxaliplatin. So we didn't see much of a substantial response in these patients for these and other reasons. What it did establish, though, is that cytoreduction itself has immense benefit when performed correctly. So the proper peritoneal stripping techniques, multivisceral resections, and obtaining complete cytoreduction in all patients that undergo CRS HIPEC for colon cancer. So the key message from that study was that cytoreduction needs to be done in a multidisciplinary fashion at an appropriate high volume center to obtain good outcomes. In terms of other cancers, I think, one of the cancers that I will say that has this arc of swinging back and forth, for example, is ovarian cancer. We know IP therapy works extremely well for ovarian cancer. We used to deliver this through ports, much like we do a port for IV chemo, but they run into the initial trials ran into a lot of problems with catheter-related complications. And as systemic therapy and maintenance treatment, especially the PARP inhibitors, got better, people moved further and further away from IP. Now there has been reignited interest in HIPEC for ovarian cancer because we have randomized data that show good overall survival in comparison to cytoreduction alone. So same thing with gastric cancer. I mean, the earlier studies were really nihilistic, but now with proper technique and more importantly with selection, we know that HIPEC has benefits in selected patients with gastric cancer. And this data is actually randomized. So in pancreas, believe it or not, there are some groups that are trying to explore this concept. The group at Mayo presented some of their preliminary work. They didn't perform conventional cytoreduction unless it was, and it was only done for very limited, like cytology positive only disease. They did only distal pancreatectomies as part of their cytoreduction, but if it was ahead of pancreas cancer, it was all treated with either IRE or SBRT. And their preliminary data shows some promise. But again, as with all these studies that utilize highly selected patients, it's hard to know how much of this can be extrapolated. So the pendulum swings back and forth and back and forth.
Looks like we have time for just one quick last question. Dr. Oschlager, 2 minutes.
Thanks. So Dr. Oschlager was asking about the relative benefit of CRS HIPEC in terms of its sort of financial impact, especially in high-grade patients where the impact in terms of long-term survival may not be as well felt as in the low-grade patients, but the cost is likely identical, arguably even more because a lot of patients undergoing systemic therapy. I would answer this by saying that I don't think there are studies that look at quality of life and cost-related, quality of life directly. But let me answer this question by giving you a simple vignette. You have a 40-year-old, gentleman with 2 children that are preschool that has high-grade appendix cancer in the peritoneum that is now doing systemic therapy with some response. While their likelihood of long-term survival is low, granted, a 5-year survival of 45 to 50% may still be meaningful in this particular patient because they could certainly meet certain goals or certain milestones that they absolutely want to see achieved. And I would also argue, much like gastric cancer, that surgery may not be a panacea. It may not really cure people, But if you have a chance of long-term survival, if you are to make it in the tail end of that curve, the only way you're going to do it is with surgery. So sure, surgery will not let everybody live to the tail end of the curve, but if there is a chance to make it to that tail end, you're not going to be able to put up that therapy. So for that reason, I would say we tend to offer these patients, even when we know that the long-term outcomes may not be as good as short-term or patients with low grade.
Thank you so much.